Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що продовжуєте приєднуватися до Case Review with ASTRO Experts for Ukraine. And today we have a session on rectal cancer, and we have two amazing speakers, Dr. Alexandra Diaz Pardo from Ohio State University and Dr. Lyudmila Bordiuh from Dnipro Regional Cancer Center. Dr. Diaz Pardo is an associate professor at Ohio State University and radiation oncologist specializing in GU and GI cancers. She received her Master of Science in Clinical and Translational Investigation at the University of Miami and completed her medical training at Pontificia Universidad Javeriana in Bogota, Colombia. She is a chair of Clinical Education Work Group of ASTRO International Committee, and she was one of the supporters and organizers of this course, so we thank her very much for this. She's also an author of numerous publications and a member of several national committees, except for Clinical Educational Work Group, ASTRO International Committee. She also is involved in NRG-GU Oncology and Alliance GI Committee. And she is also an associate editor of GI of the Practical Radiation Oncology, or we know it as PRO journal. Her research focuses on disparities, particularly in the treatment of prostate and liver cancer. She's also interested in combination of immunotherapy and radiation therapy in treatment of GI and GU malignancies. So welcome, Dr. Diaz Pardo. And our second speaker is Dr. Lyudmila Bordiuh. She is a radiation oncologist at Dnipro Regional Cancer Center, and she has 7 years of experience in her field. And she earned her medical degree from Dnipro Medical Academy and completed her residency in radiation oncology specialty in 2017. She also holds a master's degree in public administration from National Technical University Dnipro Polytechnic. Dr. Bordiuh is an active participant and volunteer of HUG, recently teaching 2 amazing lectures during our HUG OncoHub course. And for that, she received Best Educator Award. So congratulations. So just a second, I will need to mute. Okay, sorry about that. And she is also an active presenter at national conferences. And last year, she completed a short observership at Christie in Manchester, UK, and 1 month's long training at Johns Hopkins Hospital in Baltimore. So thank you so much, Dr. Bordiuh, for preparing the cases and questions for us today. And I would like to extend a very special thank you to both our speakers for preparing today's lecture, because they sacrificed their maternity leave. Both of them are on maternity leave, and they are here with us today teaching us on rectal cancer. Thank you so much for your support, and we're looking forward to hearing this lecture about rectal cancer. Dr. Diaz Pardo, please, the mic is yours.
Thank you so much for the nice introduction. Hi, everyone. It's a pleasure for me to be here. As Dr. Kowalchuk mentioned, I'm a radiation oncologist and I treat GI and GU. And let me just try to start. And today we are going to talk about rectal cancer. So we are going to start with a case. So this is a 53-year-old man without any known comorbidities who presents with rectal bleeding. A physical exam, he has a tumor that is involving the anal canal and perianal skin up to 1 centimeter beyond the anal verge. It's not possible to palpate the proximal extension of the tumor. The colonoscopy and biopsy show that he has is consistent with adenocarcinoma. The CT scans are negative for metastatic disease. The MRI, this is the MRI, and it shows this. You can see here the tumor, and it's actually, you can see it here better. it's involving the prostate. So here you can see a little bit. You can see here a little bit the involvement of the apex of the prostate. In addition, he was found to have some lymph nodes. So that's why it is considered a T4B and 1. And as I mentioned, the CT scans were negative, so it's a CT4. It's a clinical T4B and 1 and 0 rectal cancer. So this is the first poll. What treatment would you recommend? And you can see the options here, multiple options. Now with TNT, we have so many options.
And you would have to scroll down to see all the options up to H. Okay, we have 82% participating. I'm ending the poll and sharing the result. So result is showing that most people, 39%, chose option B. Then 21% option F, and then it's split 16% E and 11% A.
Okay, so I have to say that I think probably the one that would be my least favorite would be, or the would probably be A, because and maybe I should have mentioned this in the beginning. Like I included the options in the order that the treatment that you would start. But other than that, most of the other options would probably be adequate. Let's go back. So it seems like most people selected B. B is B is what we have usually used, like the standard treatment that we have used for many years. But now with TNT, there are other options that could be very that could play a good role, and that's basically what we are going to focus our presentation on today. And I'll explain a little bit more about it in a few minutes. Okay, so this was assuming. Sorry, I think I'm in the other screen. Okay. Oh. Okay, so the first question was for a T4B patient and positive. What if your patient was a patient with clinical T3 and 0 rectal cancer? So would your treatment recommendations change? And basically we have the same options as for the last poll.
So we have 89% responding, ending the poll, sharing the result.
Okay, so, I'm sorry.
Yeah, go ahead. So majority, 24% chose option C, 22% option B, and then we have 16% option A and 16% option E.
I think I agree with the majority. I think starting with short course or chemoradiation may be good options, followed by surgery, not necessarily TNT, although we are going to discuss a little bit more later when TNT would be a good option even for these patients.
Okay, thank you.
Okay, so let's start talking a little bit about the treatment options. So we have the traditional, the historical studies that focus on that show the use of neoadjuvant radiation therapy with long course chemoradiation or short course radiation therapy. That was the standard of care, or it's still the standard of care for, it has been the standard of care for so long. Then more recent data that has been talking, has focused mostly on the use of TNT, total neoadjuvant therapy, which is the use of the completing the whole treatment before surgery. So either starting with chemotherapy followed by chemoradiation, or chemoradiation followed by chemotherapy. And then we're going to talk a little bit about non-operative management. So for some patients, what to do when patients do not want surgery, or even if when can you offer that as an option? And what about those patients that you want to actually skip chemoradiation or skip radiation therapy altogether? So there is data now also to skipping radiation therapy, but who are the right, that it's only for those that are the right candidates. So who are the right candidates for that treatment? So the treatment landscape of rectal cancer has changed over time, and it's becoming more complex. So now we need personalized treatment. Okay, so let's start talking a little bit about neoadjuvant radiation therapy. And we are going to start with the historical trial. So this is the first one that I'm going to talk about is the German rectal cancer trial that compare neoadjuvant versus adjuvant chemoradiation. And the dose was 50/40 plus 540 gray boost in patients who in the adjuvant group, and they received continuous infusion 5-FU. There was no overall survival difference, but there was local recurrence difference on the intent to treat analysis, as you can tell here. And in addition to a difference in local recurrence, there was a difference in toxicity, including diarrhea, any grade 3 or 4 toxic effect. The strictures they were higher in the postoperative chemoradiotherapy arm. So overall, supporting the use of preoperative chemoradiation instead of postoperative or adjuvant chemoradiation for these patients. Now, we also have the Swedish rectal cancer trial that showed an improvement of survival with the use of short course versus doing surgery only. And this was a benefit that was seen regardless of the stage. And then we have the Australian trial that compared short course versus long course that did not show any difference in overall survival or recurrence-free survival, but it showed a difference in local recurrence. Now, so these are like the historical trials that supported the use of radiation therapy, either chemoradiation or short course radiation therapy prior to surgery. But I'm going to focus most of the rest of the talk on the total neoadjuvant therapy and non-operative management. So there are several studies that have been done focusing on the total neoadjuvant therapy over the last years. I'm going to start with the PRODIGE trial, which was a study that looked into the use of chemoradiation followed by TME, followed by adjuvant chemotherapy versus FOLFIRINOX, followed by chemoradiation, TME, and FOLFOX. So to be eligible for the trial, the patients, most of these to be eligible for participation on this trial, most of these patients had advanced tumors. It was clinical T3 or T4, not positive. Those that were not negative had to be clinical T3 or T4. Could have extramural extension, or and what they found was that there was a difference in disease-free survival and overall survival. Disease-free survival being the primary endpoint. But there was no difference on local recurrence or distant metastasis. And in conclusion, the induction chemotherapy with FOLFIRINOX before chemoradiation improved overall survival of the patients with locally advanced cancer. And then another study that also evaluated this. So the first one was the PRODIGE, that it used FOLFIRINOX to start with. So the TNT is starting with chemotherapy. And something important to remember when we start comparing with the other trials is that the chemotherapy that was used for this trial was FOLFIRINOX. So this one was starting with chemotherapy and using FOLFIRINOX. And there was an improvement of overall survival. Now, if we switch to STELLAR, STELLAR is the treatment was using short course radiation versus PRODIGE that used chemoradiation, and followed by CAPOX. So compared to chemoradiation, followed by surgery and CAPOX in the adjuvant setting. So this one used short course radiation and CAPOX, so starting with the radiation, compared to the PRODIGE that started with chemotherapy. The primary endpoint was also disease-free survival and included a population very similar to the one included in the PRODIGE trial, including distal of middle tier patients, rectal cancer patients, and included about 600 patients. Most of the patients were clinical T3 and were N positive. The difference to the anal verge was less than 10 centimeters overall. So what they found was there was a difference in disease-free survival and overall survival. And there was, for those that had complete clinical response, some of those patients who had complete clinical response did not undergo surgery. And as you can see, it was different between the ones that had TNT, 11% versus 4.4% in the chemoradiation group. This was not the original objective of the study, but an observation that they found about the clinical complete response being better for those who underwent TNT. Okay, next we have RAPIDO, which was a study that also included the use of short course radiation therapy and preparative chemoradiotherapy compared to long course chemoradiation, followed by surgery, followed by chemotherapy. This study included rectal cancer up to 16 centimeters from anal verge and included MRI with at least one of the following high-risk features: clinical T4, EMVI, N2, mesorectal fascia invasion, lateral lymph nodes that were considered metastatic. So these, as you can tell, those are very high-risk patients. They had very aggressive risk features. The primary objective was disease-related treatment failure. And that included, what I meant was local regional failure that included progression, R2 surgery, local recurrence after R0 or R1, metastasis, new colorectal cancer, or treatment-related death. So disease-related treatment failure included a significant, several different outcomes, endpoints, evaluations, and local regional failure was included early local recurrence or local and regional recurrence. So again, as I mentioned, these are more aggressive patients. Clinical T4 was 30%. Most of the patients were N positive. Patients had between, most of the patients had one or two high-risk criteria. And most of the patients could be anywhere in the rectal in the rectum. This study found a difference on disease-related treatment failure, as well as in distant metastasis, but there was no difference on local regional failure or overall survival. Now, something important is that has been discussed a lot after this was the local regional failure. So the 5-year analysis found a difference on the with a higher rate of local regional recurrence in the patients with the experimental group compared to the standard group. That's not clear what the reason is, but the only difference that they found on multivariable analysis was the mesorectum bridge. The 5-year results still showed a difference in disease-related treatment failure, favoring the experimental arm, like the TNT group. There was still a difference on distant metastasis, but there was no difference in overall survival. So overall, Rapido was a study that included very high-risk patients, and there was a change of results on local regional recurrence after longer follow-up. So the initial report at 3 years did not find any difference in local regional recurrence, but that was found in the 5-year analysis. However, something important to mention is that that was not the primary objective of the study. So it was not powered to analyze this. But it was an important observation that has been significantly, that has been discussed, and it should be taken into consideration when you are planning to start treatment. So what are the causes? We're not sure what the causes are, but was it the mesorectum bridge? It's possible that that was the difference. There was also a difference. There was, I think I may have skipped that, but there was most of the patients that had failure had 3D conformal radiation therapy instead of VMAT. So could that have been the reason? There was also, could it have been that there was prolonged treatment time prior to surgery, or differences in surgical approaches by surgeons? That would probably make sense, in the sense of, like, it's possible that the surgeons thought that they had more treatment up front, and they approached the cases differently. Or it could have just been the mesorectum bridge that overall that had been found before being an important factor to consider when you are evaluating the risk of local regional recurrence of these patients. Okay. So now let's talk about a little bit about other studies, but these ones we're going to focus on non-operative management and radiation omission. So far we have discussed PRODISH, TNT starting with chemotherapy with FOLFIRINOX, STELLAR, and Rapido that were including TNT starting with short course compared to chemoradiation. And now we are going to talk about non-operative management that includes TNT, but we're going to focus mostly on OPERA, the OPERA study, that what it analyzed was actually if you are going to talk about TNT, what is the best strategy to be able to proceed with non-operative management? So is it better to start with chemotherapy, or is it better to start with chemoradiation? So for this trial, both arms had chemoradiation. There was no short course in this trial, included an MRI stage 2 and 3 rectal cancer. And for those that did not have clinical response, proceeded with surgery, with TME surgery. But if they had a clinical response, they continued with watch and wait. So about 2/3 of the patients were clinical T3, and most of the patients were not positive, and they were very similar between both groups. Now, one of the observations from the study, is that those that, as expected, those that started with chemotherapy, when the induction chemotherapy, were more likely to have to actually receive the chemotherapy than those that started with chemoradiation. And same for the chemoradiation. For those that started with the chemoradiation, were more likely to undergo radiation than those that started with the chemotherapy arm. So they did not find any difference in disease-free survival or overall survival or local regional free survival or distant metastasis-free survival. However, for those that went to watch and wait, there was a higher rate of regrowth for those that started with the chemotherapy, and the TME-free survival was better for those that had chemoradiation. So overall, showing that what you start with, the regimen that you start with, chemotherapy versus chemoradiation, matters if the goal is to have clinical complete response and having good and being able to have sphincter preservation on the long term. So, and the last study talking about changing the standard parameters, the standard regimen that I'm going to talk about is PROSPECT. PROSPECT is the preparative treatment for locally advanced rectal cancer. This was a trial that what they did was randomizing, comparing chemotherapy only, followed by surgery only on certain patients, compared to chemoradiation, surgery, and TME. This is the primary objective was also disease-free survival and included T2, T3, and 0 or T3 and positive patients, and they have to be a sphincter preservation candidate. So the ineligibility, T4 greater than 4 pelvic lymph nodes greater than 10 millimeters, a visible tumor within 3 millimeters from the radial margin. So this is the schema. So chemoradiation followed by surgery versus chemotherapy followed by a surgery, or if there was less than 20% response, the patients will have chemoradiation. And there was adjuvant chemo afterwards. The number of cycles that patients who received the pre-op chemo in the pre-op chemo arm was lower than the number of cycles for those that had chemoradiation before. So, and this is important mentioning looking at the long-term toxicity analysis that they published later. So the patient characteristics. So most of these patients had a mid-rectal cancer tumor, mid-rectal tumor, which is different from the other studies that tended to have a lower rectal tumor. Most of these patients, about half of the patients were T3 node positive. Most of these patients had low anterior resection, 98% of the patients. And what they found was that there was no difference in disease-free survival or overall survival or freedom from local recurrence. So, however, during neoadjuvant treatment, there was a difference in the toxicity. Patients who underwent chemoradiation had more GI symptoms, as expected, but patients who received FOLFOX had more symptoms related to anxiety, loss of appetite, constipation, depression, dysphagia, mucositis, and nausea. So there were more a wide spectrum of symptoms related to the chemotherapy in the neoadjuvant treatment. And however, 12-month post-treatment, patients who received FOLFOX had less fatigue, neuropathy, and better sexual function. So when I mentioned the treatment schema, I said that the difference in cycles could be the reason why this could be different. They evaluated everyone 12 months after treatment, after surgery, which means that the patients who were on the chemoradiation arm, since they had more cycles of chemo, it would have been a shorter interval since they finished. However, it would have probably been overall a lower number of cycles, fewer cycles of chemotherapy. But at 12 months, patients who received FOLFOX had less fatigue, neuropathy, and better sexual function. And the sexual function is potentially something, it's very important for patients who underwent chemoradiation. This is definitely a side effect of chemoradiation and something to consider when you are going to discuss the potential treatment options for a patient with rectal cancer. So this is a table putting together all of these trials and showing, so for all of the patients, the primary for all of the studies, for most of the studies, the primary endpoint was disease-free survival, excepting for Rapido that it was disease-related treatment failure, so kind of the other way around, looking at the failures instead of looking at the disease-free survival. The numbers overall, so the Rapido and PRODIGE 23 found a difference in disease-free survival, or disease-free survival and disease-related treatment failure of the primary endpoint of the studies. And if you look at this one, the 3-year, so the 5-year, this was the 7-year, the ones in blue are the ones that were found a statistical significant difference. Overall, these numbers don't look too different. This one, as I said, all the way around. So this one would be like 66 versus 73, doing another simplification of what the statistics would be, but broadly speaking, which is very similar. But if you look at PROSPECT, the overall numbers are much better, particularly if you look at the local regional recurrence for PROSPECT, which was the chemotherapy study, is significantly lower overall because those were patients with fewer high-risk criteria. So it's not necessarily the same. Versus these patients, the population that was included in these patients, in these studies, were very similar. So I've talked a lot about this study. So how to put this, how to apply this. So TNT, it's an excellent option for those that have clinical T4 disease, clinical N2 disease, a low-lying rectal tumor, involved or threatened mesorectal fascia, extramural venous invasion, or clinical T3 and 0 if sphincter preservation is desired. So that would be like a short summary of when to offer TNT. The ASTRO put together some recommendations about who should benefit from this, which is basically what I just mentioned. T4, patients who have extramural vascular invasion or tumor deposits identified on MRI, threatened MRF, or threatened intersphincteric plane. They also talk about potentially discuss PROSPECT for patients who had middle or upper rectal cancer. Not so much for the low rectal cancer because you won't be able to have these were not the patients that were included in PROSPECT, and probably if you proceeded only with chemotherapy, you would not be able to offer sphincter preservation, which is what most patients would prefer if possible. What about the timing? So from some of the studies, the PRODIGE started with chemotherapy, and the other studies starting with a short course radiation. Or what about the timing? So if you are considering sphincter preservation based on the OPRA, starting with radiation would be probably the best option. However, if the patient is at high risk of metastasis, like patients who have several risk fissures, several lymph nodes, that you are concerned about the potential metastasis, starting with chemotherapy could be the best option. Overall, what about short course versus long course? Overall, if possible, long course is the preferred treatment option. That being said, I work in Ohio, but a lot of my patients come from rural areas. So there are a lot of things that you take into consideration. A lot of my patients, I actually offer a short course radiation because coming for treatment several days, several weeks may not be feasible for my patients. So short course is still an option. It's something that I still recommend for several of my patients. However, the concern is that based on the long-term results of the Rapido, that there may be a higher risk of local regional recurrence. But if those are patients who I'm considering doing TNT, but they don't have a low-lying tumor, I may be okay. Like it may be a good option to proceed with a short course followed by chemotherapy. So you have to individualize and see what are the priorities for the patient and what is feasible for your patients. What about, so non-operative management may be discussed as an alternative to TME for patients who have a clinical complete response following neoadjuvant therapy. So for those patients who have an excellent response, and what is an excellent response? That they had no obvious residual tumor on MRI or a scope, then a lot of patients, particularly those that would require an APR and an abdominal perineal resection, that would not be eligible for a sphincter preservation surgery. Considering non-operative management would be an option. What does non-operative management mean? So first, the preoperative evaluation, as I mentioned, and there's close follow-up with MRI and scopes at least every 3 months. So those are some of the recommendations. And also, just to mention that before starting treatment, if possible, checking for MSI high, microsatellite instability mutation. Checking for that is important because immunotherapy could be an option for those patients. So, okay, so now this was overall like the treatment planning, the timing, chemotherapy, chemoradiation. Let's talk about a little bit more about the treatment planning in terms of the radiation part. So again, if you have the T4B and one patient that we discussed in the beginning, what treatment, what would be your preferred treatment setup? Look, prone versus supine.
Okay, we have 81% responding, and in the poll sharing results. So majority selected supine, that's around 70%, and the rest around 30% prone.
Okay, so I think so it depends on the patient. This patient is a little big, and the prone position. So overall, if I would have to pick one setup for every rectal patient, I would probably prefer prone over supine. But there are some patients that will benefit the most from the prone setup versus the supine setup. So the patients who are small patients may not benefit as much, as there wouldn't be as much the abdomen would not fall as much into this into the belly board as much. So the idea of doing the prone setup is to decrease the dose to the small bowel, especially important for large patients. However, the other thing is that this patient, and actually, I'm sorry, I forgot that, and I forgot about the detail about this patient. It was that it was so low, the tumor was so low that actually it extended beyond the perianal verge, it extended into the perianal skin. So in this case, if I was to consider treating the inguinal nodes, I would probably want to do supine. And I'm going to talk a little bit more about the lymph nodes and when to do and the controversies about the inguinal lymph nodes. So actually, that's our next topic of discussion. What lymph node groups could you include in your treatment volumes? And I think I already said a little bit about it.
So 80% responded, ending the poll. Sharing results. So majority selected option C, mesorectal internal iliac, external iliac. And option B, 19%, and option D, 17%.
Okay, so there are controversies related to the treatment of the inguinal lymph nodes. So my personal preference would be option D, but certainly C is probably a great option as well. And we even have some discussions even at my own institution sometimes about like what the right strategy is for these patients. And actually, so the reason, so let's talk about a little bit about the treatment of the inguinal lymph nodes. So when there is involvement of the tumor that goes beyond the rectum and involves the anal canal, there is a change on the drainage of the anal canal and more which has some venous drainage, lymphatic drainage towards the inguinal lymph nodes. Therefore, if you think about in terms of extension, the possibility of dissemination would change because it would not only be to the internal iliac nodes through the not only to the internal iliac nodes and the perirectal nodes, but also to the inguinal lymph nodes, given the invasion of the anal canal. However, there was this study that was published a couple of years ago that included over 200 patients. It was a retrospective study that was from China and included tumors invading the internal or external anal sphincter determined by MRI. The treatment was either 30 grains and fractions, which is not a common regimen here in general, or 50.6 and 22 fractions. Everyone was treated with BMAT with SIB. There was no treatment or inguinal lymph nodes or external iliac nodes. And the 3-year internal iliac and external iliac node failures were 3.7 and 3.3, which you could consider that was overall low. However, the inguinal lymph node failure developing 11.4 of the patients could the lower edge of the tumor invaded below the dentate line. So it's still pretty significant. Versus 1.8% of those whom the lower edge was above the dentate line. So 11% of patients who had involvement of the dentate line or beyond that had extension into the inguinal lymph nodes. So overall, they had a low rate of inguinal and external lymph node recurrence. However, it was significantly high. It was high when there was recurrence when the tumor was below the dentate line. And you have to consider that overall, the toxicity of treating the inguinal lymph nodes is not that significant. It's probably, what I usually see is mostly acute toxicity with some dermatitis, not really many issues with long-term toxicity. It's overall well tolerated. Versus, and if you had a recurrence in the inguinal lymph nodes, the treatment of the recurrence can be challenging and more morbid because sometimes that would mean probably having inguinal dissection, which can be more morbid. Not every surgeon, particularly colorectal surgeons, have the expertise to do this surgery. So it is my personal bias is that every time I see a patient with anal canal involvement, I usually prefer to include the inguinal lymph nodes, which means I would probably include I would treat the patient in supine position, frog leg. But some people may favor just doing prone and skipping the treatment of the inguinal lymph nodes. Now, how we treat our patient. So, full disclosure, this patient was treated as part of a clinical study. So, I mentioned that the PRODIGE included the use of FOLFIRINOX versus all of the other studies that I mentioned included the use of FOLFOX. So actually, this study is that is being run here in the U.S. is randomizing the patients between FOLFOX and FOLFIRINOX, and this patient using FOLFOX as a standard of care arm. And this patient was randomized to the standard of care, the long course followed by chemotherapy. This patient was particularly interested in having a sphincter preservation if possible. Again, he was a T4 patient, T4 and 2, with significant perianal involvement. So we are not really sure that non-operative management would be feasible. However, and we had discussions with the patient, and we proceeded with TNT with long chemoradiation followed by FOLFOX. The patient was treated supine because he had perianal extension. A wire was used to delineate the extension, just to be able to see it in the scan and to make sure that we included that as part of the GTV. The patient was treated with frog leg. We treated and the CTV45 included the mesorectum, internal iliac nodes, external inguinal lymph nodes, and there was a tumor boost to 654. The BTV was 7 to 8 millimeter expansion, and he had concurrent capecitabine during radiation therapy. The contouring was done based on the contouring guidelines. These contouring guidelines were published in 2009 and included the internal iliac, mesorectum, the inguinal nodes, as I mentioned. And this is actually outpatient. So you can see the 45 and the 54 volumes. We treated the inguinal lymph nodes, the mesorectum, and this one is just to show that here is where we had the wire, just to be able to evaluate, to make sure that we cleared all the perianal extension into the volume. This patient had significant improvement of the symptoms following treatment. At presentation, he had rectal bleeding, he had very thin stools, by the end of the chemoradiation, he had more form bowel movements, the rectal bleeding had improved. He had very minimal toxicity with only grade 1 radiation dermatitis. He had mild diarrhea that was managed with low fiber diet. And after completion of chemoradiation, the patient proceeded with neoadjuvant chemotherapy with FOLFOX. Overall, the way I approach the toxicity for these patients, the most common side effects is diarrhea. We usually start with low fiber diet and then use loperamide if needed. I barely ever need to go to loperamide for these patients. And the skin toxicity, Aquaphor or petrolatum oil or silver-based cream. Okay, now we have another question. So let's say the patient went through chemoradiation, then to chemotherapy. What scans would you recommend, or what would you use to evaluate the response to treatment at this point?
So 82% participated and in the poll sharing results. So what we see, the majority, around 60%, chose option E and 37% chose option C.
Okay, I would agree with that. So particularly for those patients that you are considering non-operative management, you definitely need the CT scans, the sigmoidoscopy, and MRI to have complete evaluation of the tumor. Okay, so if the scope didn't show any obvious gross tumor, but the MRI showed 1 centimeter residual lesion, what would you recommend?
Okay, 81% responded, ending the poll and sharing results. So majority chose watch and wait. Option E, that's 42%. And the next one, biggest is split between option A, C, and D. Would you please comment?
Yeah, so I would say these are the patients that we will discuss in multidisciplinary tumor board. A biopsy of the lesion would definitely be recommended. That would probably be the first step. And reevaluation probably in 3 months, or surgery may be options depending specifically of, not every 1 centimeter lesion will look the same, right? So if it looks more like a scar and the biopsy was negative, probably reevaluation could be an option. That if it looks like it looks more concerning, surgery. So if biopsy, definitely to make sure that to have pathology and evaluate what the next steps could be. If the biopsy is negative, evaluation in 3 months of surgery if there is a high concern that even when the biopsy was negative, there is still residual tumor. But those are the cases that we would usually discuss in our multidisciplinary tumor board. Okay, so what about the follow-up? So the watch and wait follow-up. So for those patients that you continue on non-operative management, history and physical every 3 to 6 months, CEA, the DRE every 3 to 4 months for 2 years, MRI of the rectum every 6 months, as well as CT scans, and colonoscopy at 1 year following completion of therapy. And for those that continue with surgery, they will have CT scans every 6 to 12 months, H&P every 3 to 6 months, CEA every 3 to 6 months, colonoscopy in 1 year. In conclusion, the rectal cancer treatment should be personalized depending on patient staging, local tumor location, and patient preference. And any questions?
Yeah, we'll keep the questions till the end. So now we'll have Dr. Bordiuh showing her slides. She prepared some of the cases, but thank you so much, Dr. Diaz Pardo. So that was an excellent overview. Thank you. So if you stop sharing, perfect.
Can I share? Yes.
Yeah, go ahead.
Mm-hmm. Mm-hmm.
Excellent.
Thank you. Thank you, dear colleagues. Thank you, Alexander Diaz, for an interesting lecture. It was a very interesting report, and it was really important information about trials. It's really nice and organized information for us. I will have a lot of questions for you about in our cases, so let's start doing it. First patient, it's young man, 42 years old. As you see on this slide, how it's rectum cancer, T4A, and 2 and 1, and 1 because of nodes. And lower you can see describing of CT, MRI, and colonoscopy. Of course, patient had an examination in full examination. In our clinic, we use NCCN guidelines to treat our patient, but this patient is not so classic. You can see on the rectum, that the tumor starts in 60 millimeters from the anus. I will take 60 millimeters from the anus. But very interesting information is that about conglomerates in the pelvis nodes up 52 and 35 millimeters with invasion of the internal iliac vessels and the right ureter. On MRI, we have the same information, pretty the same, but some other information about nodes. You can see that it's really big conglomerate of lymph nodes, 75, 50, 50 millimeters. But on the left, small nodes and common iliac are 25 and 20 millimeters. So we have MRF plus and VI plus in this case, and information about colonoscopy. Of course, this patient starts from MDT. MDT decided to use chemotherapy like first step for this treatment of this patient. So during 2 months, this patient received 4 courses. But after 4 courses, our clinical oncology decided to use MRI to understand what is the dynamic of this patient. And here is a small video about the situation on MRI. As you can see, on the left side of the slide, you can see that conglomerate of lymph nodes are become even bigger. So 75, 55, 65 millimeters, but on the right, I'm sorry, on the left, and the common iliac are pretty stabilized. So we have, in conclusion, we have a negative dynamic in this patient and MDT. And as you understand, negative dynamic, yes, MDT recommended palliative radiation therapy. But in that moment when we saw this patient on our radiation oncology department, because of the young age, we decided to use radiation therapy in the definitive dose with capecitabine, like recommended in NCCN 80-25 milligram per meter square twice per day per os. It wasn't easy, of course. Here is on this slide, you can see contours of this patient. Eye of almost all structure for your to be confident and for comfortable understanding situation. And I can show you that in the pink color, it's 40 grays structure, period 40. In the yellow color, you can see it's 50 gray, and 60 gray, it's 4 conglomerate nodes in the pelvic and in the start of and end of aortic fields. Near from L2 till S3, there are big conglomerate of lymph nodes. The field was near 80 centimeters long, and it wasn't easy for our medical physicist, of course, too. You can see here doses, and the diverse statistic, how we treat this patient. As you can understand, the big bowel and the small bowel, we didn't cross the line. They didn't cross in normal dose. Of course, we overdose. And the back bowel and bowel at all. But other ORs are pretty nice. We take new information from 2022 from this article. Our medical physicists try to use the newest information in such cases. About this treatment, this patient. Here is a small video about last XVI. In this patient, as you can see, the weight of this patient becomes smaller, -5 kilograms during the treatment. And about the treatment at all, after the third fraction, the patient had a complaint of the leg voiding and swelling of the lower extremities. Our oncologist saw this patient and decided to use nephrostomy. Nephrostomy was with both sides because there were a big problem with that. During treatment, complaints were of the mucus discharge in the fecus, general weakness, and fatigue. After treatment, after treatment and the last two fraction, patient had a complaint of diarrhea. This patient is on call with us, with our department and with me, so we know about his feelings. We help this patient to treat and to care about diarrhea. For now, complaints of general weakness, reduction of the weight, as I told, was -5 kilograms. So we help this patient to stabilize all his problems and help with caring. My question about this difficult patient: do you agree with chosen tactic? Which option would you choose in this case? Maybe you prefer to use longer chemotherapy, or maybe some other dose in this case. Of course, I understand that 60 gray are pretty high at all, but NCCN allowed us to use dose more than 54 in some cases which we need. Do you agree with doses? And what do you can recommend in this case?
This is a very challenging case and very difficult young patient. So we recently had a case, similar case, and first of all, this case would be discussing multidisciplinary tumor board, which sounds like you did too, and it depends, because one option is considering switching chemotherapy. This patient had already had 4 cycles progression, and maybe considering another chemotherapy, considering trying to go with another chemotherapy with like FOLFIRINOX. It could be an option, or radiation therapy can be considered. However, one has to, like, the advantage of doing chemotherapy is that you at least can evaluate the overall response. And this patient, the main issue that this patient is going to have on the long term is going to be probably distant metastasis. He had significant burden or lymphadenopathy in the para-aortic lymph nodes. So the main concern on the long term is going to be distant metastasis. That's his highest risk, more than local issues. It seems like locally he hadn't had any significant spread yet. So, I mean, chemoradiation could be considered, but I think that probably our preference would have been doing a different chemotherapy regimen. But again, it's not that doing chemoradiation is wrong by any means. It's just which one would you prefer? I don't think that it's a right or wrong answer. The doses, so I think it was you were very brave going with 60 gray. I'm a little nervous to give that dose to a large volume. 60, sometimes we use it when it's not close to the bow, because the max dose that we try to use, the absolute max dose that we try to give to the bow is 60 gray. And we are concerned about the long-term risk of fistulas with doses higher than that. So I try to stay with 54 to 56 gray to less than 15 cc and 60 gray as the max dose. So I don't think I will have felt completely comfortable proceeding with this. But we know that colorectal cancer is radio resistant, and sometimes you have to use higher doses to be able to achieve response. Something to consider is that this patient has metastatic disease again. In the issue that the thing that you should be the most concerned about is the development of distant metastases. So my approach usually, again, it's not right or wrong. It's just to consider like the potential toxicity that you are giving to a patient whose highest risk is probably distant metastasis. And I think I will have probably just gone up to 54 gray, like to the large tumor. But that being said, it seems like the patient did well. However, you still have to be concerned about the long-term toxicity. But overall, this is a very challenging case, and I don't think there is a right or wrong answer. It's a very challenging case in a young patient.
And what is your opinion about chemotherapy after radiation therapy?
Well, I think the question would have been why they do a different type of chemotherapy before radiation. So like that would have been the better
That's
option.
something that you have done in your place, right?
Yeah.
Other line of care, chemotherapy.
Yeah. Yeah, that would have probably been my preferred.
Yes, I agree that the other line of chemotherapy are longer courses and longer courses in months. I mean, of chemotherapy must be preferred in these cases, of course. But that MDT works like that, so we must work with such information.
Dr. Bordiuh, you were showing that the bowel Dmax was 66 gray, and did the patient have any GI toxicity?
Just diarrhea in the end. That's all.
Okay, and so you also showed that on the cone beam CT, the patient lost a lot of weight, right?
Yes.
Did you replan? Did you replan?
It's no, we didn't replan. Lost weight, it was in the end of the treatment when before diarrhea started. There was some intoxication this patient. We use a lot of medicine to help this patient, to care about this patient. It was suppositorium. From the start of the treatment in Ukraine, we practiced to use caring about patient from the start. So we recommend to use suppositorium in the rectum from the maybe first till 5 fractions. And patient start to treat to caring about his rectum. And the reaction when I talked about the reactions with doctors from the USA, we had a conclusion that in Ukraine we have not so many reaction in the in the rectal cancer, because we use suppository from the start. We had some idea about this. Maybe it helps us to help this patient to be without some difficult complication, or we will wait in the future.
So it's a suppository. What's the medication that you use a suppository?
Suppository is like an oil and the methylpsylium, and it can be hyaluronic, something suppository with hyaluronic acid. So in Ukraine, there are many variants for the patient, so we help before the complaints.
So the suppository is to prevent constipation?
Yeah. Can I start? Second case?
Yeah, sure, go ahead.
In this case, it's not so interesting as first case. It's like more classic. It's rectum T3D and 2BM0, adenocarcinoma, of course. CT, you can see here information about CT. And the MRI, we had MRF plus, MRI plus, elevator minus, sphincter minus. Information about colonoscopy you can see here too. MDT recommended start from the chemotherapy, and the second, after that, use radiation therapy for treatment this patient. You can see that patient received 6 courses of Capriox chemotherapy. And the second part, we decided to use radiation therapy with capecitabine for this patient. Here you can see the contour which we used for this patient. It was internal iliac, mesorectum. We use 50.4 gray for the yellow. PTV, as you see on contours, and the PTV 45 grays for the blue one. Here is a scrolling of the contours. The result of work of medical physicists, you can see here, it was some problems of, again, with back bowel, but not so big problem as the first case. And other ORs are pretty good situation. My question is, in this case, what do you agree with chosen tactic? And it's about that we talk about today. You told us about TNT. What your favorite variant in TNT in these cases, for these cases, for example? So we started like in second line chemotherapy, and then long course of chemoradiation therapy. We use that. But maybe you but maybe you would like Oprah told us, to use start from one course chemoradiation and then chemotherapy, and it can be maybe better variant for such patient in the tactic watch and wait in the end. I mean, do you agree with this?
The tumor was mid-rectum, right?
I'm sorry?
The tumor was in the mid-rectum, right?
So, one moment. It's, no, it's lower ampulla region.
Okay. So, and let me see again the volumes, if you don't mind.
Is here or MRI?
So, I think, so there are two things with this one. I think I would probably lean towards starting with chemoradiation. However, if the patient is in N2, the patient may be a higher risk of having metastasis. So starting with chemotherapy may not be a bad option. Then it depends on the patient and like how against the patient is also against having a surgical resection afterwards. If the patient is, no matter what, I don't want to have a surgery that will remove my sphincter, then starting chemoradiation will probably be even more important. But given that the patient is N2, I don't think it's wrong to start with chemotherapy either.
Thank you. What do you think about doses? 50.4, and I mean, do you use 50.4 to the whole pelvis with nodes? If yes, in what cases you use it?
So we usually use 45 with boost to 50.4. And it's that to include the mesorectum and some distance superiorly and inferiorly. So it is, for some patients, the boost ends up being very similar to, depending on how large the tumor is and the location. Some patients, they may include the whole thing, may end up going basically to 50.4. Patients tolerate it very well. There are even patients who are enrolling in this study that I just mentioned, that is enrolling nationwide. So even going to 54, and patients usually tolerate very well. So Just to summarize, I usually go to 45 with a boost of 50.4, but we are starting to push a little bit on the dose, and sometimes we even go to 54.
Thank you. And what about 5 in 5 fraction? Do you recommend to use in this case or no? And how do you like this method?
That would probably not be my preferred option based on the results of Rapido. It's usually I would probably be a little bit more worried about the recurrence, local regional recurrence. I would probably favor chemoradiation.
So when you can use chemoradiation with long course, you try to use this variant, yes, like
I'm
long
sorry?
course.
Long course, yeah.
Yes, when you can afford for patient to use long course with chemoradiation therapy. I mean, you try to use this variant.
Yeah.
After what period of time do you recommend surgical treatment? So if we don't go in the tactic watch and wait, what is variant for surgical treatment? In 4 weeks, 9 weeks, 12 weeks. So NCCN told us some big period of time after radiation therapy.
So now we are treating more with the TNT, starting with chemoradiation followed by chemo. So it's a little different because then it will be after the chemo completion. But if it was starting with chemotherapy and then followed by radiation or chemoradiation, then about 2 weeks after the short course and about 8 to 12 weeks for the long course.
And if we finished with chemotherapy, if you go in like Oprah recommend long course after after the long course chemotherapy, then in what period of time you recommend?
So the chemotherapy, the surgery after chemotherapy, it's usually about 6 weeks, 4 to 6 weeks. I think they are doing the surgery.
And what you can recommend for us? What is your favorite strategy in treatment of rectal cancer?
Overall, again, it depends on the case. You can approach, but I think the cases that we see the most are very locally advanced and or very low lying tumors. So we tend to use the most starting with chemoradiation followed by chemotherapy. That's probably the most commonly used given the population that we have.
Thank you. It was a very interesting to have a chat with you. Thank you.
Thank you, Dr. Bordiuh. So we have a lot of questions in the chat, so we'll start going through them. From Dr. Bordiuh, the question, what dose do you recommend for inguinal nodes, total dose and everyday dose? Thank you.
I usually treat to 45 gray. So when as part of the long course chemoradiation, so that's another thing. I don't think I will feel comfortable treating as part of a short course. I will probably only do it as part of a long course.
Long course.
And 45 gray to the lymph nodes at 1.8 gray per fraction.
Okay, thank you. Question from Dr. Marcenius. Dear Dr. Diaz Pardo, thank you for the great talk. In your opinion, is there a place for brachytherapy in the treatment of rectal cancer?
We don't usually use it. There are some studies using it mostly in the recurrent setting. But to be honest with you, we don't use it. I'm not as familiar with the use of brachytherapy for rectal cancer.
And that's coming from Europe, right? So Europeans are using. Question from Dr. Metzak. What's your strategy on not low-lying, locally advanced rectal cancer patients in case of 20% or more response of chemotherapy? Would you provide chemoradiation or TME?
So that's basically the treatment regimen based on prospect, right? So it depends on, does the patient meet the criteria for prospect enrollment. Like if the patient meets the criteria and he will have been enrolled in prospect, saying like a small tumor that is high, that it is a T3 mostly, proceeding according to prospect is probably appropriate. So going from chemotherapy, going to surgery. However, if you have a patient who is really a T4 patient who has multiple lymph nodes, that a higher risk patient, that is not the patient that was enrolled. That was not this population that was studied on. So I would probably favor chemoradiation for that patient.
Okay, sounds good. Another question from Dr. Mitzak. Do you give just immunotherapy to MSI-H patient without any other treatment in your clinic? And thank you so much for this great presentation.
Thank you. So yes, basically the medical oncologist starts with immunotherapy. And depending on the response, we may or may not see that patient. So most patients respond well. But I've treated patients that started with immunotherapy-based systemic therapy, and they did not respond well. So then we have proceeded with chemoradiation afterwards.
Okay, I see. The question from Dr. Sokolowska. Dr. Diaz Pardo, thank you so much for such an excellent lecture, important advice. I have a question about re-irradiation option after 6 months of short course of RT followed by 4 cycles of chemo. Patient had a rectal bleeding. Any possibility to stop bleeding? Impossible because the tumor has started too low and it was low mid-rectum involvement. Would you provide re-irradiation? If yes, what treatment scheme would you choose?
That's a very tough case.
Yeah.
So, so if it was, so I think it depends a little bit. So if it's 6 months since the patient finished the short course radiation, or 6 months since he finished the 4 cycles of chemo, because if he has already had at least a year, I think I would feel more comfortable re-radiating. We have had cases like that, and unfortunately, you can. I think I actually had a very, very similar case, and we did a similar 5x5. The problem is that the patient had recurrence the first time. This is not going to probably stop it again. So it's going to require, if surgery is an option, surgery could be included, could be used. But you can try radiation. It will probably cause a temporary, it will stop the treatment and the bleeding temporarily. But the main issue is that he had a very poor response the first time, won't probably respond the second time.
What would be your dose for re-irradiation?
We have done, so since it's been, she replied 6 months after radiation. That's a very short interval.
Yeah.
I would probably do 20 and 5. I think that was what we did with my patient. Again, it's probably going to be a temporary response, not a long-term response. It's a very complex scenario.
Okay, very good. So we don't have any more questions in the chat. If somebody wants to ask a question, please turn on your cameras, microphones, ask a question. In the meantime, I'll ask about the future trials. Are there any exciting trials that are going on right now and you are waiting for results? Something to wait for?
The Alliance trial that I just mentioned, that it's randomizing patients between induction in chemotherapy with FOLFIRINOX versus FOLFOX. I think it's going to answer a question on like what's the right chemotherapy as far as CNT. I think that's probably the main one I can think of that it's enrolling. There are some other studies actually, but mostly for the oligo-metastatic setting. There is a study looking at being more aggressive with local therapy for patients with metastatic disease. that one is currently enrolling, and that's going to be a very important study.
Okay. We at Stanford we do have a short course study, so it's 5 x 5, but with 5 grade boost. So I think we have a trial like this. So people are saying, thank you so much. Thank you for the lectures. And Dr. Sokolowska said that she chose the same treatment option, what you would do. So that's great.
Great.
Yeah, that's awesome. Thank you so much, both of you. If people would like to take a group photo with Dr. Diaz Pardo, she helped us organize this course and she was a big supporter. So we'd like to thank her and take a group photo with her. That would be
Thank you
great.
so much.
Yeah. Let me show the view in gallery and then I'll take a group photo. Oh, so nice to see you all. If more people can turn on their cameras, we'll wait a little bit. Oh, nice.
Thank you for the invitation. It was an honor for me to participate today. It was really great. If you have any questions, Dr. Kovalchuk, maybe you can share my email if needed. If you have any
Yeah,
questions,
that's
happy to
great.
help.
Yeah, thank you so much, Dr. Diaz. And we know that you are taking care of your newborn baby, and thank you for taking the time to meet with us today. So smile, everyone. I'm going to take a photo. Excellent. Great photo. Thank you. I will share with everyone.
Thank
Have a
you.
good evening. Thank you, Dr. Diaz. Thank you, Dr.
Thank you.
Bordiuh. It was
Thank you.
excellent. Thank you. Bye-bye.
Bye-bye. Thank you.